Welcome to the Deep Dive, the show that converts complex medical surgical concepts into the practical, actionable knowledge you need to excel in clinical practice.
Today, we are undertaking a critical and really unavoidable topic for every single nurse out there.
That's right, the assessment and management of patients with allergic disorders.
And this is truly foundational material. You, the listener, you're going to encounter allergic disorders absolutely everywhere. It might be, managing chronic, just burdensome conditions like allergic rhinitis in a community clinic.
Sure.
Or it might be managing a full-blown life-threatening crisis in the ER or the ICU. So expert nursing management, it's just integral to safe practice.
Exactly. Our clinical mission today is to give you a systematic shortcut to mastering all this. We really need to unpack the core pathophysiology, what is going wrong at the cellular level,
Right.
and then the systematic assessment framework, the meds, and most crucially, the rapid life-saving nursing actions you need for those allergic crises.
We really should start with a crisp terminology check, because these terms, they get used interchangeably all the time, but clinically they mean very different things.
Okay, let's go.
So we talk about antigens. These are, broad foreign invaders the body reacts to. But when we narrow that down to the world of allergy, we use the term allergens.
So allergens are a type of antigen.
Exactly. They're specific, normally harmless substances like dust or pollen or certain foods that cause an inappropriate immune response.
And that inappropriate, often harmful immune system reaction is what we define as an allergy. We also have three essential terms that really frame the severity and the nature of the response. First up, anaphylaxis.
The big one. That is the rapid, multi-system, life-threatening reaction.
There's hypersensitivity.
Which is really the umbrella term for any abnormal or excessive immune reaction to a stimulus.
And third, atopy. This one's a crucial distinction, isn't it?
It is, because atopy refers specifically to IgE-mediated diseases that have a strong genetic link. So we're talking about chronic conditions, things like allergic rhinitis, asthma, and atopic dermatitis.
So if a patient is atopic, their immune system is basically just genetically primed for that IgE-driven overreaction.
That's the perfect way to put it.
And before we leave this intro, we have to define the two most common skin manifestations you're going to see. First, urticaria.
Which is just the medical term for hives, those transient, round, elevated, and usually very, very itchy lesions.
And then angioedema.
Right, and that's the deeper, more diffuse swelling of the subcutaneous tissue and the mucous membranes. And if that involves the airway, well, it is instantly life-threatening.
Okay, with those foundational concepts locked down, let's dive into the core engine of the allergic response, the physiology.
Let's do it.
Okay, so let's unpack the body's layers of defense. For nursing students, we really need to understand where the defense system starts and where the breakdown happens.
Right. So the body's first line of defense it's purely structural. It's the epithelial cells lining the skin and the respiratory GI and GU tracts. They just physically block invaders.
A physical barrier.
A physical barrier. But when a foreign protein, an antigen, gets through those barriers, the body launches its second line, and that's the specific antibody response.
And the body starts producing these specialized antibodies designed to take out that specific invader.
Immediately. And they work by coating the antigen, neutralizing it, and precipitating it out of solutions so that specialized white blood cells, the phagocytic cells, can just sweep them up and get rid of them.
This whole process relies on a really complex network of immune cells, mostly the lymphocytes, B cells and T cells. Can you break down the specific jobs of B cells and T cells in this whole immune dance?
Absolutely. So the B cells, or B lymphocytes, they're the foundation of what we call humoral or antibody-mediated immunity. When a B cell encounters an antigen, it recognizes it's triggered to proliferate and differentiate into what are called plasma cells. And it's these plasma cells that are the antibody factories. They secrete the immunoglobulins, the antibodies, into the bloodstream.
And the critical feature of B cells is their specificity.
Precisely. Each B cell is programmed to produce only one specific type of antibody, and that antibody targets only one specific antigen. We often think of it as that lock and key mechanism. It ensures the response is just incredibly targeted.
Okay, so that's B cells. Now T cells, or T lymphocytes, they're responsible for cellular or cell-mediated immunity. So they don't produce antibodies. What's their role?
They're the directors, and sometimes the frontline killers. We focus a lot on the T helper cells.
Assistants.
They are essential assistants. They are crucial for orchestrating the entire immune response. They secrete these things called lymphokines, which are substances that just stimulate the activity of other cells, including B cells and macrophages.
And the macrophages are the cleanup crew.
the cleanup crew, and also the lookouts. They engulf debris, but just as importantly, they present the antigen to the T cells. They basically kick off the whole specific immune response.
So when we're talking about antibodies, the ones secreted by B cells, we're talking about immunoglobulins, or Ig. And there are 5 classes, right? IgG, IgA, IgM, IgD, and the star of our discussion today, IgE.
Yes, IgE is the antibody of allergy, and its placement in the body is really strategic. The IgE-producing cells are located mostly in the respiratory and intestinal mucosa.
Which makes perfect sense because most allergens get in through inhalation or ingestion.
Exactly. IgE is also involved in fighting some parasitic infections, but for our purposes today, it is the key indicator of an allergic disposition.
So let's follow the path of IgE in the allergic process and move into the core pathophysiology of sensitization. How does a normally harmless substance, like pollen, turn into a life-threatening crisis?
It all starts with the first exposure, the sensitization. When the allergen is first encountered, the body produces IgE against it. These IgE molecules, they don't just float around freely for long. They rapidly bind to the surfaces of these highly specialized cells, namely the mast cells and basophils.
And this is where that critical analogy of the loaded gun comes in.
Exactly. Mast cells are strategically located all over the body and the skin, the respiratory tract, the GI tract, just ready for action. The problem starts on the next exposure.
Right.
When the allergen is encountered again, it acts like a bridge, cross-linking 2 or more of those IgE molecules that are already sitting on the mast cell surface. This cross-linking signals the mast cell to degranulate.
It essentially explodes.
It explodes and releases a massive dose of powerful chemical mediators, and that is the definition of an immediate hypersensitivity reaction.
We should probably quickly clarify the nature of these antigens. Most true allergens, like pollen or animal dander, are complete protein antigens. They stimulate a full response.
Right. But then you have these low molecular weight substances like certain medications, which can't stimulate an antibody response on their own.
And those are called haptens.
Haptens, they're incomplete antigens. For a hapten to kick off an allergic response, it has to first bind to a tissue or a serum protein. It's basically piggybacking on a carrier complex before it can successfully stimulate antibody production.
And this distinction is vital when you're investigating drug allergies.
It is, but whether it's a complete protein or a hapten complex, the end result is the same. Sensitization, which primes the body for a massive reaction on re-exposure.
Now we are entering the critical area of clinical application. If the release of these chemical mediators is the bomb, we need to know what's in the payload.
Because these mediators dictate every single symptom the patient has and guide all of our medication choices. This is where we shift from, abstract definitions to clinical urgency.
Right.
We categorize them into primary mediators, the ones that are preformed and immediately released from the mast cells, and secondary mediators, which are generated seconds or minutes later.
And the major primary player, the first one out of the gate, is histamine. Why is its timing so important?
Because its effects are so fast and so dramatic, they typically peak within 5 to 10 minutes of antigen contact. Histamine is responsible for all those classic immediate signs of allergy.
And those signs are wide-ranging.
Right.
It causes erythema and localized edema, which we see as the wheals and the classic pruritus, the itching.
In the vasculature, it causes small vessel vasodilation, which leads to flushing and hypotension, while at the same time, it constricts the larger vessels.
And crucially, histamine causes the contraction of bronchial smooth muscle.
Right. This is what leads to wheezing and bronchospasm, immediately impairing gas exchange. And let's not forget the GI tract, where it increases gastric and mucosal secretions, leader to potential cramping and diarrhea.
This is why knowing the receptor types is so important for pharmacology.
Yep.
Histamine acts on H1 receptors, found mainly on bronchiolar and vascular smooth muscle, and H2 receptors, which are on the gastric parietal cells.
Precisely. The older H1 antagonists, like diphenhydramine, they block those acute effects on the respiratory system and the skin. The H2 antagonists, like cimetidine or famotidine, they target gastric acid.
And in severe anaphylaxis, we sometimes use H2 blockers as adjunct therapy, right?
Yes, alongside H1 blockers to optimize treatment, but they are absolutely not the primary line of defense against airway closure.
Okay, moving beyond histamine, we have other preformed mediators. There's eosinophil chemotactic factor of anaphylaxis, or ECFA.
Which basically just signals for eosinophils to join the party. And then there's platelet activating factor, or PAF.
Right.
And PAF initiates several processes.
Right.
platelet aggregation, leukocyte infiltration, and it further increases vascular permeability. It's a powerful contributor to bronchoconstriction and vasodilation, just feeding that systemic reaction.
And then prostaglandins.
Prostaglandins cause smooth muscle contraction, vasodilation, increased capillary permeability, and importantly, they sensitize pain receptors, which contributes to the local heat, redness, and swelling.
So those are the immediate hits, the first wave. But where does the chemical cascade turn deadly? That brings us to the secondary mediators.
These are the ones that are synthesized or activated in response to that initial mast cell explosion. And this is where we have to focus intensely on leukotrienes.
Also known as the slow-reacting substance of anaphylaxis.
Yes. And while they take a little longer to become fully active, they are catastrophic.
Why catastrophic? What's the clinical takeaway on their potency?
They initiate a prolonged, severe inflammatory response. They cause smooth muscle contraction, massive mucus secretion. But the critical number is this. Leukotrienes are 100 to 1,000 times more potent than histamine in causing bronchospasm.
1,000 times.
1,000 times. If a patient's reaction progresses to severe airway compromise, leukotrienes are the primary culprits driving that sustained, life-threatening bronchospasm.
That magnitude of difference is precisely why anaphylaxis doesn't just resolve quickly on its own. And then we also have bradykinin contributing to the disaster.
Bradykinin is a powerful vasopressor precursor. It causes a profound increase in vascular permeability, which leads to significant edema swelling of the airway being the worst possible outcome.
And it also causes vasodilation, driving hypotension.
Exactly. It drives systemic hypotension, smooth muscle contraction, and pain. So when you layer the actions of histamine for the immediate drop, leukotrienes for the airway closure, and bradykinin for the capillary leak and swelling, you have the entire recipe for anaphylactic shock and cardiovascular collapse.
Okay, so understanding that chemistry allows us to categorize the clinical picture. The term hypersensitivity is key. It means an excessive or aberrant immune response, almost always following that initial sensitization.
And to guide our management, we classify these reactions into 4 types.
Let's start with the most urgent. Type I, or anaphylactic, immediate.
This is the IgE-mediated reaction we just spent all that time describing, the one driven by mast cell degranulation.
And the hallmark is just how fast it happens. Onset is in minutes, and the clinical picture is severe. Laryngeal edema, bronchospasm, profound hypotension, and shock.
Examples would be acute extrinsic asthma, allergic rhinitis, and of course, systemic reactions to insect venom or medications.
And it's so important to remember that even after you stabilize them, a delayed or biphasic reaction can occur up to 24 hours later. That really underscores the need for observation.
It really does. Moving to type 2, the cytotoxic reaction. This is where the immune system makes a mistaken identity error.
Okay.
It involves IgG or IgM antibodies binding to antigens that are actually located on the patient's own cell surfaces or basement membranes.
And when that antibody binds, it activates the complement system, which leads to cell lysis and massive tissue damage.
The quintessential example every nurse must know is the hemolytic transfusion reaction. If a type O patient, for instance, mistakenly receives type A blood,
Their body attacks it.
their pre-existing anti-A antibodies bind to the transfused type A red blood cells, causing their destruction hemolysis. This leads to acute kidney injury, fever, and potentially shock.
And other type 2 examples would include things like myasthenia gravis or certain drug-induced anemias. Okay, type 3 is the immune complex reaction. Here, the problem isn't the antibody binding directly to a cell, but the formation of these insoluble complexes between the antigen and the antibody.
Exactly. And because these complexes are too large to be efficiently cleared by phagocytic cells, they just circulate and then get deposited in sensitive areas. The vascular endothelium, joints, and kidneys are favorite targets. And this deposition triggers a severe inflammatory response.
So this mechanism is central to several complex autoimmune disorders. We're thinking rheumatoid arthritis, systemic lupus erythematosus, SLE.
Right, and clinically, the patient might present with urticaria, joint pain, fever, and vasculitis.
Finally, we have type 5, the delayed or cellular reaction. This one's completely different, isn't it?
Completely, because it's T-cell mediated, not antibody mediated, and it takes 24 to 48 hours to fully manifest after exposure.
And it involves T cells releasing lymphokines, which attracts macrophages, and they in turn release lysozymes that cause localized tissue damage.
The simplest and most common example we see in healthcare is the positive PPD skin test for tuberculosis, the erythema and induration. That's the T cells reacting to the antigen, but it only shows up 48 to 72 hours later.
And other examples would be contact dermatitis from poison ivy or nickel, or the tissue damage you see in Hashimoto's thyroiditis. Understanding these four types really dictates the urgency and the pharmacological approach we take.
It's everything.
Given the range of reactions we just covered, from minutes to days, the initial comprehensive assessment is the cornerstone of allergic care.
Absolutely.
For the nursing student, you need a systematic, structured approach. We need to basically internalize the comprehensive allergy history. It should function like your verbal checklist.
And the nurse's role here is invaluable. The patient's history is often scattered and anecdotal, so we have to systematically assess the chief complaint and the severity of the current illness. But the really diagnostic information lies in the collateral allergic symptoms.
Right, we have to ask about symptoms across every single body system.
Every single one.
Okay, let's talk specifics. You need to systematically check the eyes. Is there pruritus, swelling, discharge, ears, any itching, fullness, or that popping feeling?
Yeah.
Nose. The classic triad, right? Sneezing, obstruction, and pruritus.
And the chest for cough, wheezing, dyspnea, sputum production, and of course the skin for any sign of dermatitis, urticaria, or angioedema.
That history deep dive also has to include a family history of allergy, which reinforces that concept of atopy. And crucially, we need a timeline. What previous treatments did they try? Antihistamines, steroids, immunotherapy, and did they actually work?
And timing is everything in connecting the exposure to the reaction. You need details on when symptoms occur. Is it seasonal or perennial? Does it happen at night or only during the day? Is there a difference between weekends and weekdays?
We even ask about its relation to the menstrual cycle or their occupation.
Yes, and environmental factors are the main triggers. We have to ask about the patient's living environment, the age of the house, the heating system, basement dampness, and especially the presence of pets.
Does going on vacation provide relief?
Exactly. Does a geographical change help? We also ask about exposure to specific physical agents or habits like tobacco smoke, air conditioning, and use of strong perfumes or chemicals.
And finally, we have to document specific food exposures, especially common culprits like nuts, citrus fruits, melons, and the most open-ended, but often most insightful question.
What does the patient believe makes their symptoms worse or provides them relief?
Right.
Once that history points toward an allergic disorder, then we move to diagnostic evaluation. While the history is primary, certain blood tests can give us some supportive data.
For instance, the complete blood count with differential. We are zeroing in on the eosinophil count. While normal is generally 2 to 5% of white blood cells, a level greater than 5 to 10% in the blood, sputum, or nasal secretions strongly supports an active allergic disorder diagnosis.
We also measure total serum immunoglobulin E, or IgE levels. High levels really support the diagnosis of an IgE-mediated disease, particularly atopy.
However, the most accurate confirmation of allergy is still skin testing.
Right. This is done either via superficial application, like a prick or scratch test, or an intradermal injection of the antigen. But this procedure carries real risk, and we have to adhere strictly to safety protocols.
This is a massive quality and safety alert for nurses. First, testing is never performed if the patient is experiencing bronchospasm.
Never.
Second, the less invasive epicutaneous, the prick or scratch tests, are always performed before an intradermal injection.
And the most critical rule, emergency equipment, including injectable epinephrine, must be readily accessible and checked before you even begin testing. The risk of inducing anaphylaxis is real.
And we have to make sure medication adherence is addressed before the test. Corticosteroids and all antihistamines, even the over-the-counter ones, they suppress the skin's reactivity.
So to prevent a false negative result, these medications have to be withheld for 48 to 96 hours before the test.
When a test is positive, we describe the reaction as a wheal and flare. The wheal is that localized, round, reddened elevation.
And the flare is the diffuse redness surrounding it. Occasionally, we even see these irregular projections called pseudopodia. We use a grading system to document the size and intensity of the reaction, which helps guide the management strategy.
And a quick note on alternatives. The serum-specific IgE blood test, which used to be called RAS, it detects free IgE in the blood.
And it's safer because it eliminates the risk of a systemic reaction, and it's not affected by current medications. However, it's generally more expensive and often less sensitive than a well-executed intradermal skin test.
Okay, we shift now to the ultimate clinical priority. The life-threatening type hypersensitivity reaction, anaphylaxis. We have to treat this with extreme urgency.
Extreme urgency.
And two concepts define that urgency. One, The severity of the reaction is directly proportional to how rapidly the symptoms begin. The faster the onset, the more aggressive the intervention must be.
And two, the severity of a previous reaction does not predict the severity of the next one. A patient who had mild hives last time may experience fatal shock this time. You can never, ever underestimate an allergic response.
Never.
So recapping the mechanism, massive, sudden cellular degranulation floods the body with histamine, prostaglandins, and those highly potent leukotrienes. The result is rapid systemic effects.
Sudden vascular permeability leading to massive fluid shifts and hypotension.
And severe sustained bronchoconstriction.
We also have to be aware of what are called anaphylactoid reactions.
Right. These are clinically identical to true anaphylaxis. They present with the same airway compromise and shock, but they're triggered through non-IgE-mediated mechanisms.
Like reactions to certain drugs or even physical exertion.
Exactly. The critical takeaway for the nurse is that regardless of the mechanism, the clinical presentation demands the identical immediate treatment.
So what are the most common serious culprits?
Antibiotics are at the top, and penicillin is historically the most common drug to cause fatal anaphylaxis. Radiocontrast agents are another major offender.
And outside of medication?
Look for specific foods. Peanuts, tree nuts, shellfish, and insect stings, particularly from the Hymenoptera family like bees, wasps, and hornets.
Understanding the progression of symptoms is absolutely essential for early recognition. So let's start with mild reactions. These usually start within the first 2 hours. The patient might report some peripheral tingling, a sensation of warmth, fullness in the mouth or throat, nasal congestion, and pruritus. This is the time to intervene rapidly.
Then you get to moderate reactions. The symptoms escalate quickly. They include flushing, intense warmth, escalating anxiety, and itching. More seriously, they involve objective signs of respiratory distress, bronchospasm, and early laryngeal edema, leading to dyspnea, coughing, and wheezing.
And finally, severe reactions, anaphylactic shock. Those abrupt and rapidly progressive. Patient develops severe dyspnea, cyanosis, stridor from the laryngeal edema, and profound hypotension.
They might develop GI symptoms too, like severe cramping and vomiting. And without immediate treatment, this leads rapidly to cardiovascular collapse, coma, and cardiac arrest.
So prevention is our first mandate. Rigorous allergen avoidance, systematic screening for allergies, especially before giving any parenteral medication. But for anyone at known risk, the epinephrine auto-injector is a required intervention.
They must carry it, and they must be proficient in its use.
If an anaphylactic reaction is suspected, medical management requires immediate priorities focusing on respiratory and cardiovascular stability. This is an ABC priority. It's time for the rapid response team.
If cardiac arrest has occurred, you initiate CPR. Supplemental oxygen has to be provided immediately for any signs of cyanosis, dyspnea, or wheezing. But the definitive first-line life-saving intervention is epinephrine.
1 to 1,000 dilution, administered subcutaneously or intramuscularly in the upper extremity or thigh.
And epinephrine is the pharmacological countermeasure for everything that went wrong. It's a powerful vasoconstrictor to reverse that catastrophic vasodilation and hypotension.
And critically, it's a bronchodilator to open the airways that were closed by histamine and leukotrienes.
It is so vital to stress that epinephrine is the priority. Antihistamines and corticosteroids are adjunct therapy. They help stabilize the patient and prevent later phase reactions, but they are not substitutes for epinephrine.
Not at all.
After the initial dose, a continuous IV infusion of epi may be required. But you have to be cautious, especially in the elderly or those with cardiac disease, because of the cardiac stimulating effects of the drug.
And to manage the resulting shock, we're using IV fluids, volume expanders, and possibly vasopressors to restore blood pressure.
And for persistent severe bronchospasm, epinephrine or corticosteroids may be added.
Post-reaction care is just as crucial due to the risk of a rebound or delayed reaction, often occurring 4 to 8 hours later, even after the initial symptoms seem to go away.
Right, so patients who've had anaphylaxis must be transported to the ED for monitoring. And observation time is individualized. It's going to be longer for ingested allergens, persistent hypotension, or a history of pre-existing asthma.
As nurses, our hands-on role is immediate. You assess ABCs, you notify the team, and you rapidly initiate emergency measures. Let's walk through the essential patient education for the epinephrine auto-injector, because patient self-administration buys crucial time.
The steps have to be clear and demonstrated repeatedly. First, you remove the auto-injector from its carrying tube. Grasp the unit with the orange tip, that's the needle end pointing down. Then remove the blue safety release cap.
Next, hold the black tip near the outer thigh. A common error is injecting into the wrong area, like the buttocks or fingers. Swing and jab firmly into the outer thigh at a 90-degree angle until you hear a clear click.
And you hold the injector firmly against the thigh for about 10 seconds to make sure the full dose is administered. Then you remove it, gently massage the area, and the final non-negotiable step is immediately call 911 or seek medical attention.
Even if you feel better.
Even if the patient feels better. They need professional monitoring and potentially a second dose.
It's worth noting that research has really shown the effectiveness of using demonstration and video instructions, not just written materials, to make sure patients retain this life-saving knowledge.
It makes all the difference.
Shifting now from the acute crisis to the chronic burden, let's talk about allergic rhinitis, or hay fever. It is the most common respiratory allergy, and it afflicts millions and really impacts quality of life.
Its seasonal pattern provides a major clue to diagnosis. We can track the pollens. Tree pollen peaks in early spring, grass pollen in midsummer, and weed pollen, especially ragweed, in the early fall.
And mold spores can be a problem year-round, can't they?
Oh yeah, especially in warm, damp environments. Pathophysiologically, it's a type IgE-mediated response localized to the nasal mucosa. The inhaled antigen lands on the respiratory lining, IgE binds to mast cells, and mediators flood the tissues.
And the diagnostic hallmark in nasal secretions is the presence of eosinophilia in the tissues. The clinical manifestations are what patients report. Those sneezing fits, persistent rhinorrhea, nasal itching, conjunctivitis, and obstruction. But the nurse also needs to look for objective signs.
Right. The signs include allergic shiners, that's the infraorbital edema, and darkening from venous congestion. You might also notice the allergic salute,
which is that horizontal nasal crease from chronically rubbing the nose upward to relieve itching.
Yep. And inside the nose, the mucosa often looks grayish and swollen, which helps distinguish it from the red, inflamed mucosa of an infection.
And complications are common due to all that chronic inflammation. Chronic sinusitis, otitis media, even migraine headaches.
And some adults develop what's called oral allergy syndrome, or OAS, where raw fruits and vegetables like apples or melons cause itching that's confined just to the mouth or throat.
Management is staged. Avoidance, pharmacologic therapy, or immunotherapy. And avoidance is always the first goal.
And avoidance measures require really detailed patient teaching. Things like using air conditioning instead of opening windows, using HEPA air cleaners, removing dust-collecting items like carpets and drapes, and removing pets, especially from the bedroom.
Essential actions also include using those impermeable dust mite covers on mattresses and pillows, changing clothes and showering right after spending time outside, and frequent saline nasal irrigation to wash away allergens.
When avoidance isn't enough, pharmacology steps in, and we have to distinguish clearly between the two generations of H1 antihistamines.
The first-generation agents, like diphenhydramine, they're highly effective H1 blockers, but they readily cross the blood-brain barrier,
which causes significant CNS effects, sedation, drowsiness, cognitive impairment that can affect driving or school performance. They also have those anticholinergic side effects, dry mouth, urinary hesitancy, confusion, which makes them a poor choice for older adults. They're often on the Beers criteria.
Right, which is why the second-generation agents, loratadine, cetirizine, fexofenadine, are the preferred choice.
They're called non-sedating because they primarily target peripheral H1 receptors and don't cross the blood-brain barrier as easily. This minimizes sedation and cognitive issues.
A quick note on adjuncts. H2 blockers, like famotidine, may be added to augment the H1 effects in some allergic conditions, but they can't treat rhinitis or urticaria by themselves.
And we have to caution patients about combination products, the ones with an antihistamine plus a decongestant. The decongestant component carries a systemic risk of increasing blood pressure, especially in patients who already have hypertension.
Now let's talk about the gold standard pharmacotherapy for this.
Okay.
Corticosteroid nasal sprays.
These are recognized as the single most effective agent for allergic rhinitis. They're powerful anti-inflammatories working directly on the nasal mucosa, shrinking the tissue and reducing mediator release.
The key patient teaching point here is adherence and timing. Maximal anti-inflammatory effect can take 1 to 2 weeks of consistent daily use. They are not rescue medications.
That's so important. And the dosage should be tapered to the lowest effective dose once symptoms are controlled. Side effects are generally mild and localized. Mucosal drying, burning, or maybe mild nosebleeds.
Next are the adrenergic agents, or decongestants, like oral pseudoephedrine or topical oxymetazoline sprays. They work by causing powerful vasoconstriction to shrink that mucosal swelling.
But the caution here is paramount. Topical nasal spray use must be strictly limited to a few days. Overuse leads to rhinitis medicamentosa.
which is a severe rebound congestion and dependency, often worse than the original allergy symptoms.
Much worse. Oral agents, while they avoid rebound congestion, carry systemic risks like hypertension, arrhythmias, and CNS stimulation, making them generally not a first-line agent.
We also use mast cell stabilizers like crinoline sodium. These stabilize the mast cell membrane, preventing the release of mediators like histamine.
They're often used prophylactically, ideally 30 minutes before you know you're going to be exposed, and they take a week or more for beneficial effects.
Finally, leukotriene receptor antagonists, or LTRAs, such as montelukast, they block the synthesis or action of leukotrienes, those powerful bronchoconstrictors.
And like nasal steroids, LTRAs are for long-term daily control. They are completely ineffective as rescue medications. A critical nursing implication is monitoring for adverse neuropsychiatric changes, anxiety, depression, insomnia, which must be reported immediately.
And if all that fails or is poorly tolerated, we move to the final management strategy, allergen immunotherapy, or AIT. This is the controlled administration of gradually increasing allergen doses.
The goals here are physiological modulation. We want to reduce circulating IgE levels and stimulate the production of IgG, which we often call the blocking antibody, because it competes for the allergen before it can reach the mast cell.
And it's pretty effective for common allergens like tree pollen, dust mites, and cat dander.
It is. AIT is indicated for patients with rhinitis or asthma, a history of systemic insect venom reactions, or those who need to avoid long-term medication use. But the contraindications are vital for safety.
We have to screen out patients who are using beta blockers or ACE inhibitors.
Because those drugs can mask or exacerbate the signs of anaphylaxis, which is a significant risk during treatment. Other contraindications include significant cardiac or pulmonary disease, or patients who just can't adhere to the strict schedule and the mandatory post-injection monitoring.
Let's differentiate the delivery methods. Subcutaneous immunotherapy, SCIT, involves serial injections. Because this carries the risk of systemic and potentially fatal anaphylaxis, especially during the dose buildup phase, the Quality and Safety Alert mandates a 30-minute observation period post-injection with immediate access to epinephrine.
Always. Then there's sublingual immunotherapy, SLAT, which uses dissolving tablets or liquid under the tongue. It offers comparable efficacy but generally results in fewer systemic side effects, mostly just local irritation.
And a newer method is epicutaneous immunotherapy, ENTI, which is still investigational. It delivers the dose via patch on the skin, and it's hypothesized to reduce systemic risk because of the lower dose delivery to a less vascular area. Applying the nursing process to rhinitis starts with a focused assessment, looking for those fits of sneezing, clear watery discharge, and lacrimation. We must also try to capture the patient's subjective experience before symptoms fully erupt, that telling pruritus or tingling.
And you should ask if emotional stress or fatigue seems to trigger a symptom escalation.
Key nursing diagnoses flowing from this are impaired breathing pattern, lack of knowledge regarding treatment and avoidance, and difficulty coping with chronic illness.
And the collaborative problems, the complications we manage with the medical team include potential anaphylaxis, worsening impaired breathing, and of course non-adherence to the prescribed medication regimen.
Our interventions really center on improving the breathing pattern. This involves rigorous reinforcement of environmental modification and avoidance strategies, minimizing exposure to URIs, and ensuring the patient adheres to their control medications.
Promoting understanding is essential for managing this chronic disease. We have to clearly explain the difference between rescue medications like antihistamines, which are used as needed when symptomatic,
And control medications like corticosteroid sprays and LTRAs, which are taken daily to prevent symptoms. Patients often struggle with the fact that control meds don't provide immediate relief.
They really do. We also have to address coping and the psychosocial burden. Chronic vigilance and the inability to escape symptoms can be just profoundly demoralizing. The nurse should acknowledge this difficulty, encourage open verbalization of feelings, and help the patient identify feasible lifestyle adjustments, like switching from carpet to hard flooring.
Monitoring for complications means staying vigilant for any escalation toward anaphylaxis, especially in patients receiving immunotherapy. Respiratory and cardiovascular status has to be regularly checked, and patients with known severe allergies must have their auto-injectable epinephrine device on hand.
For home and transitional care, our teaching points have to be detailed and practical. This includes environmental restructuring, removing drapes, using hypoallergenic mattress covers, implementing HEPA filters. Patients should be taught to wear a mask for high-exposure activities like gardening or dusting, and to avoid strong perfumes and sprays.
And we circle back to the critical teachings on nasal spray misuse. We must warn patients about the overuse of topical sympathomimetic decongestants leading to rhinitis medicamentosa.
If a patient develops that rebound congestion and dependency, the topical agent has to be discontinued immediately and completely. The patient needs to understand that continuing the spray only feeds the cycle and makes their congestion worse.
Now let's rapidly broaden our scope to several other high-priority allergic disorders, starting with contact dermatitis, an inflammatory skin reaction to an outside substance.
And we differentiate between two types. Irritant contact dermatitis is the most common, about 80%. It's non-immunologic. It's direct chemical damage from things like strong soaps, solvents, or frequent hand washing.
So it causes dryness, fissures, and vesiculation. And treatment is just identifying and removing the irritant and using heavy emollients.
Right. The remaining 20% is allergic contact dermatitis, which is a type IV delayed hypersensitivity reaction. It's T-cell mediated, resulting from contact with antigens like nickel, specific dyes, or poison ivy.
And the symptoms, itching, redness, blistering, and oozing, are usually strictly limited to the site of contact.
Exactly. Diagnosis for the allergic type is confirmed by patch testing. Management involves strict avoidance, cool compresses, and topical or systemic corticosteroids if the reaction is widespread. The delayed nature means the patient might not connect the exposure to the rash for 48 to 72 hours.
Next, atopic dermatitis, eczema. This is a chronic inflammatory disorder with a strong genetic component involving IgE. The core pathophysiology is a compromised or leaky skin barrier,
Often due to defective filaggrin genes. This leaky barrier lets allergens penetrate and moisture escape, which leads to dry, intensely pruritic skin. This sets up the classic itch-scratch cycle, which ultimately leads to skin thickening or lichenification.
Clinically, this is often the first step in what we call the Atopic March. A child with eczema progresses to an IgE food allergy, and then later to asthma and allergic rhinitis.
The whole progression. So management focuses heavily on avoiding irritants and rigorous skin hydration. Topical corticosteroids are the mainstay during acute flares, with topical calcineurin inhibitors used for sensitive areas like the face.
And the crucial nursing teaching is skin hydration. Using thick cream moisturizers, applied immediately within minutes of stepping out of a hydrating bath or shower to lock that moisture in.
Now, a high alert topic, drug hypersensitivity. This is the leading cause of fatal anaphylaxis, accounting for 43% of deaths, with parenteral administration carrying the highest risk.
Reactions can be immediate, which is type 1, within an hour, or delayed, taking weeks and involving types 2, 3, or 4.
Immediate reactions are that type I anaphylaxis, common with beta-lactam antibiotics, but the delayed reactions are complex and often missed.
Type 2, cytotoxic, can manifest as antibody-mediated destruction of blood cells, leading to hemolytic anemia or thrombocytopenia. We sometimes see that with cephalosporins or penicillin.
And type 3, immune complex, can present as serum sickness or vasculitis, often taking a week or more to develop after exposure to things like antitoxins or certain vaccines.
And type 4, T-cell mediated, includes the most severe delayed skin reactions like Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TOK.
These are extensive, life-threatening epidermal necrosis reactions that take days to weeks to develop, and we also have to recognize pseudoallergic drug reactions.
Which look like allergies but aren't.
Right. They're non-IgE mast cell degranulation caused by agents like radiocontrast or opioids, and histamines may still help, but the mechanism is different.
Let's move to urticaria hives and angioedema. Urticaria is a type I reaction pruritic wheals that are pink or red. If it's acute, it lasts less than 6 weeks. If it's chronic, it's longer.
And management is based on eliminating the cause and using second-generation H1 antihistamines, often at high doses, up to 4 times the standard, or specialized biological agents for refractory chronic cases.
Angioedema is that deep, non-pruritic, brawny swelling. And this is life-threatening if it involves the larynx. Critically, we have to distinguish the cause because the treatment is completely different.
So important.
We have mast cell-mediated histaminergic angioedema. This is usually associated with accompanying urticaria, flushing, or bronchospasm. Because it's histamine-driven, it's treated like anaphylaxis with epinephrine, H1H2 blockers, and corticosteroids.
Then we have bradykinin-mediated angioedema. This is a clinical crisis because it is not associated with urticaria or bronchospasm. It is caused by the potent vasodilator, bradykinin, commonly triggered by ACE inhibitor medications.
And the nurse must recognize that traditional anaphylaxis treatment, antihistamines and steroids, is ineffective.
Completely ineffective. Treatment requires specialized agents like a catabond or C1 inhibitor concentrate. This clinical differentiation is absolutely critical for patient safety.
And we should briefly note hereditary angioedema, or HAE, which is a rare genetic bradykinin-mediated disorder due to C1 inhibitor deficiency. Attacks can be severe, involving massive abdominal or laryngeal swelling, necessitating readiness for a tracheostomy.
Finally, food allergy. This is IgE-mediated type I. Common adult triggers are fish, shellfish, peanuts, and tree nuts. Manifestations range from localized oral swelling to severe anaphylaxis, which is most severe with nuts.
Diagnosis relies on history, skin tests, and, if needed, the gold standard: the clinician-supervised oral food challenge. Management is strict avoidance and carrying an epinephrine auto-injector.
We also use oral immunotherapy, or OIT, where small, increasing doses are ingested to raise the threshold required to trigger a reaction. It is a risk management strategy, not a cure.
Not a cure.
Our last specific disorder is latex allergy. This reaction to rubber tree proteins is decreasing, but it remains high risk for specific groups, like healthcare workers and patients with multiple surgeries. It's also known to cross-react with foods like kiwis, bananas, and chestnuts.
And it can present in three ways: irritant contact dermatitis, which is non-immunologic damage; allergic contact dermatitis, a type IV delayed T-cell reaction; and immediate hypersensitivity, type I, which carries a high risk for anaphylaxis minutes after exposure.
The nursing mandate here is universal assessment. Assess all patients for latex allergy before any invasive procedure. Advise high-risk patients on avoidance, using non-latex alternatives like nitrile, carrying medical ID, and carrying epinephrine.
That was an expansive and essential deep dive. We started with the molecular pathway of IgE and mast cell degranulation, navigated the 4 distinct types of hypersensitivity reactions, detailed the comprehensive nursing assessment, and moved into the specific life-saving management strategies for both acute anaphylaxis and chronic rhinitis.
The essential nursing takeaways for you, the learner, they really boil down to 3 priorities. 1. Vigilant assessment. The comprehensive allergy history is a non-negotiable tool for identifying triggers and risk.
2. Airway first. Anaphylaxis is a type A crisis requiring immediate recognition and rapid, definitive intervention. Epinephrine is always the priority, followed by adjunct therapy.
And 3. Master adherence education. Patients must clearly understand the difference between symptomatic rescue medications like antihistamines and daily control medications like steroids and LTRAs, and the crucial danger of topical nasal spray overuse leading to rebound congestion.
Considering the principle of the Atopic March, that documented trajectory where early childhood atopic dermatitis often precedes food allergies, asthma, and rhinitis, it leaves us with a provocative question.
If nursing science and practice were to prioritize early, aggressive hydration and management of the infant skin barrier, could we fundamentally interrupt this progression and alter the entire lifetime trajectory of allergic disease for future generations?
That's a powerful thought on the intersection of preventative care and chronic disease. Thank you for taking this deep dive with us into the essentials of allergic disorder management. We appreciate you taking the time to sharpen your clinical knowledge.
We'll see you next time.